When I say chemotherapy-induced nausea and vomiting, or CINV, I'm referring specifically to traditional chemotherapy. I want to make the distinguish from targeted therapies that target a specific protein on the tumor. Chemotherapy is highly effective at destroying or shrinking tumors by targeting the DNA of the cancer cells, either directly or indirectly. The problem is that all dividing cells, whether healthy or cancerous, must undergo DNA replication. Chemotherapy attacks this fundamental process. So while the goal is to kill rapidly dividing cancer cells, any normal cells that divide quickly will also be hit. We see these rapidly dividing cells in the bone marrow, leading to decrease in blood cell counts, hair follicles, leading to hair loss, and lastly, the digestive tract, leading to nausea, mouth sores, and diarrhea. The mechanism behind the nausea and vomiting begins when chemotherapy damages the GI mucosa, causing the enterochromaffin cells to release serotonin, also known as 5-hydroxytryptamine or 5-HT. The released serotonin binds to the vagal afferent nerves. This sends a message to the CTZ and NTS, which will stimulate the vomiting center, leading to that vomiting reflex. Other neurotransmitters like substance P and dopamine are released by neurons in the CTZ and NTS after detecting chemotherapy in the blood. When released, these neurotransmitters bind to dopamine and substance P receptors, which promotes the stimulation of the vomiting center. The nausea often occurs as the body prepares to expel contents. The CTZ name doesn't mean it's related to chemotherapy. Chemo just refers to that area of the brain being able to detect chemicals. So in general, we have three main players involved in CINV: serotonin, substance P, and dopamine. But their clinical relevance differ depending on the time that has elapsed since the chemo was administered. So for serotonin, its role in CINV is more significant during the acute phase, meaning within 24 hours of the chemo administration. Substance P and dopamine play a role in the delayed phase of CINV, so at least 24 hours after the chemo, and this persists up to 4 days. Other less important hormones and neurotransmitters that play a role in CINV includes histamine, acetylcholine, GABA, and prostaglandins. To manage CINV, we need to know the emetic risk potential of the chemo. Not all chemos are created the same. Some have a higher risk of causing CINV than others. Knowing the difference in the emetic risk will help guide treatments. So we have high, moderate, low, and minimal. But I will only be focusing on the first three. Patients on high emetic chemotherapy have a 90% or greater risk of developing CINV. Moderate is 30 to 90%, and low is 10 to 30% risk of developing CINV. Please note that these percentages refer to patients who did not receive antiemetics medications for prevention. So if we give antiemetics, then we expect the risk of developing the CINV to decrease. Some examples of high emetic chemos include cisplatin, adriamycin, and cytoxin combination, dacarbazine, carboplatin at an AUC of 4 or greater. Examples of moderate emetic risk chemo includes doxorubicin, irinotecan, and oxaliplatin. Low emetic risk chemo include paclitaxel, docetaxel, and gemcitabine. This list is very short. It's meant to just give you some examples, but you can always refer to the NCCN guidelines for a more comprehensive list to determine the emetic risk. I will include the link in the description. Also, patients may have other specific factors that can potentially increase your risk of CINV. Not the focus of this video, but I have some examples here just for your information. So the female sex, because they generally have higher vagal sensitivity and enhanced activation of nausea pathways. Younger patients, because they have a more reactive CTZ and stronger neurotransmitter responses. Patients with a history of motion sickness. Patients who have anxiety tend to have strong expectations of nausea and can condition their body to expect worsening symptoms. Lastly, regular alcohol drinkers often have desensitized emetic pathways and higher dopamine and serotonin tolerance. Non-drinkers lack this, making them more prone to nausea. The guidelines make treatment recommendations based on the chemotherapy emetic risk, not based on the patient-specific risk factors that we just went through. So we will follow the NCCN guideline recommendations in this video. The primary goal is to prevent the CINV, meaning we don't even want it to occur because it becomes very difficult to manage. Instead, we will give prophylactic drugs to help prevent it. In general, the antiemetic regimen that we will use depends on the emetic risk of the chemo. So as per the NCCN guidelines, patients receiving highly emetic chemotherapy should receive 4-drug combination. For moderate emetic chemo, 2 to 3 drug regimens are recommended. And then we have the low emetic risk. We give these patients single agents. The antiemetic options include 5-HT3 receptor inhibitors, NK1 inhibitors, dopamine inhibitors, and corticosteroids. Although there are other hormones and neurotransmitters that play a role in CINV and can be potential targets for drugs, these are the main ones recommended. And how we schedule them with the patient's chemo varies. So on the day of the chemo infusion, it's labeled as day 1, and then the subsequent days are 2 to 4. The reason being some of the chemotherapy can cause acute CINV occurring within 24 hours and also delayed. So for highly emetic chemo regimens, we are concerned about acute and delayed nausea and vomiting. So for day 1, the patient will receive all 4 drug classes as recommended, and days 2 to 4, we will continue everything but the 5-HT3 inhibitors because they don't play much of a role in the delayed CINV. For moderate emetic chemo, 2 to 3 drug regimens are recommended. So one being the 5-HT3 inhibitors, a corticosteroid, plus or minus the dopamine inhibitor or an NK1 inhibitor. We continue the corticosteroid plus or minus the dopamine inhibitor or NK1 inhibitor, depending on which one was used day 1. And then we have the low emetic risk agents, and our only concern is the acute phase. So we give these patients single agents like dexamethasone or the 5-HT3 inhibitors. We can now learn a little bit more about the 4 drug classes that are mainly used for prevention and then cover some examples before bringing the video to an end. By the way, if I'm doing a good job explaining this topic, all I ask for is to hit the like button. Thank you. The 5-HT3 inhibitors work by blocking the serotonin receptors in the GI and also the CNS. Examples of the drugs in this class include ondansetron, granisetron, and palonosetron. Side effects include headaches, QT prolongation, which is one of the main reasons why the ondansetron is capped at 24 milligrams oral and 16 milligrams IV. And lastly, constipation. Next, we have the NK1 inhibitors, which work by blocking substance P receptors in the CNS. Examples of the NK1 inhibitors include aprepitant, fosaprepitant, and rolapitant. Aprepitant is a CYP3A4 inhibitor, and unfortunately, dexamethasone is a CYP3A4 substrate. This is important to know because dexamethasone is one of the corticosteroids we tend to use as part of the combination for CINV. When dexamethasone is administered with aprepitant, there is a decrease in the breakdown of the dexamethasone, so the maximum dose is 12 milligrams. Also, fosaprepitant, which is a prodrug of aprepitant, is an IV formulation that is administered only on day 1 of the patient's chemo cycle and can cover acute CINV and also delayed CINV, so we don't have to administer more fosaprepitant during days 2 to 4. Side effects of the NK1 inhibitors include headache, fatigue, and diarrhea. Next, we have the dopamine receptor inhibitors. Now, despite the name, this agent doesn't just block dopamine, but also serotonin, histamine, and muscarinic receptors. This dopamine inhibitor is olanzapine, well known as an antipsychotic, specifically an atypical antipsychotic. Dosing for CINV is similar to antipsychotic dosing, so usually 5 to 10 milligrams. Side effects include movement disorders or EPS, sedation, and weight gain. Next, we have the corticosteroids. The antiemetic mechanism for nausea is not fully understood, but it is believed to work by acting on the vomiting center in the CNS. It also has an anti-inflammatory effect that can reduce inflammation in the GI tract and may work by interacting with neurotransmitters like serotonin and inhibiting prostaglandin synthesis. Examples include dexamethasone and methylprednisolone. Side effects are hyperglycemia, GI issues, and mood changes. Now, despite appropriate antiemetic prophylaxis, some patients may still experience what we call breakthrough emesis, which occurs and requires the use of rescue therapy. These are usually ordered for the patient to take at home as needed only when they are experiencing nausea. Now, let's go through one patient case example to put all of this together. So Mr. Kane is a 62-year-old man with locally advanced HPV-negative squamous cell carcinoma of the oral pharynx. His history includes alcohol use, he smokes 1 pack per day, and he has no significant kidney disease. The treatment he will be receiving is definitive chemoradiation with cisplatin 100 milligrams per meter square IV every 3 weeks. Now let's take a look at the questions. So first, cisplatin at 100 milligrams per meter square is classified as having what emetogenic risk? You can pause the video if you need to, but the answer here is high emetic risk. In this case, for cisplatin, regardless of the dose, it's treated as a high emetic risk chemo. You may see some other agents that are dose dependent, but in this case, it's not. Next question, which prophylactic antiemetic regimen is recommended for this patient for cisplatin-based therapy on day 1? The correct answer here is C, because cisplatin is highly emetic, so it's preferred to use 4-drug antiemetic combination. You may also see 3-drug combination being used in practice, so everything excluding the olanzapine. This was the old recommendation, but now 4 is preferred. Question number 3, which medications should be continued for days 2 to 4 to manage delayed CINV? So the correct answer here is A. We don't typically continue the 5-HT3 antagonist in the delayed phase, as the pathophysiology of that phase is not mediated by serotonin. And that would be the end of this video. I hope I was able to break down this topic in the simplest way for you to understand. I hope you enjoyed the patient case questions as well. If you did, please hit the like button, subscribe, and leave any comments down below. Thank you for watching this video, and take care, and happy holidays.